Great to meet you all virtually. So I'm Vishakha, as Anna has said. I'm a consultant genetic counsellor within my NHS practice. I work at Guy's and St Thomas's, but I also work across other providers as well. So lovely to have you with me, and thank you to Ovacome for the invitation. These are some of my disclosures, in particular, just to draw your attention to the fact that I was a committee member for the recent NICE familial ovarian cancer guideline as well, which of course I'll be talking about. So really what I thought we could do is spend the next sort of 40 minutes thinking about what the landscape of familial risk and genetics looks like in ovarian cancer. What are some of the things that are currently recommended and not, but then move on to the impact this has on a family and the support avenues available. So this nicely takes me to the aims of the next sort of half an hour, 40 minutes. And I hope that this is what you thought you were signing up to. But if not, please don't hesitate to put your questions in the chat. And I know Anna's going to help me in the background with that. And I'm hoping to have a few minutes towards the end to have a sort of live question and answer session if it's not covered in my talk. So just to give ourselves a little bit of a background, these are some of the things that we've known for a long time. We've known that late cancer diagnosis remains a problem, particularly in the ovarian cancer setting, and there is a real need to detect disease at an early curative stage. There's also a need to identify those at increased risk of any cancer, really, so that we can begin to offer targeted surveillance and, if they develop cancer, more targeted therapies and treatment. We also know that there is a heightened public and patient awareness of the fact that genetic risk can contribute to the overall cancer risk. We know, certainly in our service, that cancer genetics sort of referrals and cases account for 40% of the total referrals that we do get, and that a risk assessment when we're thinking about a family history of cancer provides opportunities for prevention, but also early intervention in the wider family. The current NHS England threshold to offer genetic testing when a hereditary cancer susceptibility is in question is about 10%, and I'll explain that a little bit later in terms of what that means. A lot of work has been done in the last decade, actually, in trying to develop, sort of processes, pathways, and really harness what genetics can give us in terms of more personalized medicine. So there's been some large-scale Department of Health initiatives, such as the 100,000 Genome Project, Generation Genome Report. So there's a real positive movement, I think, in this space, and definitely an acknowledgement that genetics is here to stay and has an important place when we're thinking about cancer susceptibility in the inherited context. Taking a few steps back, there were some stark statistics given to the healthcare community in the early 2000s, which you may have come across by Ovarian Cancer Action. And these, really told us that more needed to be done. So we knew at that time that 29% of women diagnosed with ovarian cancer were not being offered BRCA testing, for example, and almost 70% of people had never heard of the existence of a BRCA gene mutation, or the fact that a high-risk gene mutation might be responsible. The last two bullets are probably something that worry me personally, in that 33% of respondents had received no counselling or no genetic counselling, I should say, before making a decision around genetic testing, and a larger proportion, so almost 42%, failed to receive adequate support after their genetic test results. So I think there are still gaps in how this is done, but hopefully between then and now we've got better. So it would be good to maybe compare what your experience has been in this space. We have got better because we now have the NHS Genomic Test Directory, and this has really sort of standardized the criteria used for offering genetic testing throughout England, which is really helpful because it's also enabled clinicians sitting outside clinical genetics to start offering genetic testing. So this is what we call mainstream genetic testing or point of care genetic testing. So often women, when they receive a diagnosis of ovarian cancer, may be offered this through their oncology team or surgical services, not solely through clinical genetics. And what that does and has done is it's widened that net of offer, it's widened that offer. So there's multiple clinicians that can assess whether an individual or family might be eligible for testing and make that happen. The other thing that's happened since then is that there's been a sort of reconfiguration of the NHS genetic testing laboratories, which are now called genomic laboratory hubs or GLHs. The testing threshold for cancer susceptibility still stands at 10%, which I mentioned a couple of slides previously. And what this means is that there has to be an at least 10% or higher chance of detecting a disease-causing gene variant, or what we call a mutation or an alteration or a pathogenic variant. These all are used interchangeably if that test is done. And a combination of criteria is used. So you can see on this slide, there's some family history criteria, and it's telling us that, for example, if a woman has a diagnosis of an epithelial ovarian cancer and has a first-degree relative with epithelial ovarian cancer, she would be eligible for gene testing. And a first-degree relative is really children and siblings or parents, so very close relatives. And then there's wider history as well. Taking a few steps ahead, more recently, so this year, the NICE guidelines came out with some sort of recommendations around the threshold at which gene testing should be offered based on the age of the person. And you can see here that there is, a progressive sort of, as a woman gets, or a person gets older, the threshold is higher. And that's to reflect the fact that actually, still that the vast majority of cancer diagnoses are age-related events, and they're not caused by the presence of a high-risk gene mutation. So for that reason, if the age of an individual is older, you'd want to raise that threshold a wee bit to make sure that you're actually picking up those gene mutations if they are there, rather than testing the whole population, which may not necessarily need it. There is some what I would call reconciliation that needs to happen, though, because as I showed you in the last slide, the NHS England threshold for genetic testing is still at 10%, whereas the NICE recommendation is lower. And so I'm sure discussions need to be had in terms of how we bridge that gap. What the NICE guidelines also did was to give us clarity on a few other things which are really important and crucial for care around ovarian cancer. And that is that it gave us a clear direction on which people should seek a risk assessment and where they should seek that. It also tells us that if there are changes to an individual's medical or family history, they need to come back for a re-risk assessment if they've already had one previously. And that's to reflect that actually, with evolving histories, eligibility might change and things like genetic testing might become an option, or we might give slightly different advice about screening or some other management interventions. There's a real emphasis on using the wider multidisciplinary team in this care model. And I think that's really great because if you think about it, actually managing any cancer diagnosis, particularly in the inherited context, you're thinking about lots of relatives that may be receiving care across the country, across the globe, in fact. And so really harnessing that MDT care model when we're thinking about this. Central to the guidelines remains genetic counselling, and was absolutely delighted to see that, obviously. And if you do a control F, you'll see that genetic counselling is dotted through the guidelines, which really reflects the value of the process. And we'll talk about what that is, because I know some of you may have questions about exactly what genetic counselling is. It also tells us that provision around psychological support and access to sort of other services that might be necessary for support and information is key. So I think we have the building blocks now for really championing what we need for ovarian cancer patients, for our families with hereditary ovarian cancer risks, which is great. And this has been a space I know that charities like Ovacome and others have been championing for a long time. So hopefully this will help us all. Taking you to some biology now, and I just wanted to revise really together some of the different gynecological female cancers that do happen. And this is a sort of picture that tells us the different organs within this system that can be prone to developing malignancies. Today, the focus is really on the tubo-ovarian cancer, so cancers arising the ovaries and the fallopian tubes and the peritoneum. So that's the focus really of today's talk. We know that the vast majority of these will be epithelial in nature. And how common are these, or how frequently are they found in our population? So you'll see that actually ovarian cancer is the 6th most common female cancer in our country. And it approximately affects, I think, about 1 in 50 women in the general population. And we know that for most women, the diagnosis, if it does happen, tends to happen in sort of the menopausal years in the general population. That's important as a reference point, because when we're talking about the inherited setting, I think it's helpful sometimes to compare what is expected to happen because of non-inherited risk factors compared to inherited risk factors, and what's the difference. So the WHO has lots of really helpful classifications around cancer, but in ovarian cancer, you can see what that looks like here. And you'll see that almost 90% of ovarian cancer diagnoses are epithelial. This sort of cell-based approach, as I call it, is really helpful to think about which risk factors might be driving that type of cancer. It also helps develop targeted treatments, and to some extent can help us quantify what risk might lie in a family, depending on the type of ovarian cancer that individual has presented with. We also use it to determine which genetic tests might be appropriate. So I showed you that previous slide with the criteria, and it clearly said epithelial ovarian cancer. And that ties in with this cell-based approach and this WHO classification. So it's helpful to remember that just because perhaps, for example, someone might offer a genetic test which has 100 genes that you could have analyzed, it may not actually be necessary, and it may not be appropriate or helpful, because often some of those other types of ovarian cancers may not fit that bracket, and you may not need it because your personal diagnosis is of a particular cell type, if that makes sense. And moving on from that, so this slide really is to break that down and show you, what the hereditary cancer syndromes sort of look like. And here, it's this line here where it says hereditary cancer syndrome. So high-grade serous carcinoma, and you can see that the largest contributor still is hereditary breast and ovarian cancer, which could be attributed to alterations in the known BRCA1 and BRCA2 genes, and some newer genes as well, which I'll tell you about. And if the ovarian cancer histological type is endometrioid or clear cell, well, actually, it's less likely to be caused by things like BRCA alterations, and more likely to be caused by a condition called Lynch syndrome. And so there's an overlap in the ovarian cancer sort of space with the breast side of things, but also the sort of colorectal and bowel and Lynch side of things. And that's, again, really important to remember, and why often you might be asked to provide a copy of the histology of the diagnosis, or you might be asked, what was the type of ovarian cancer or the type of cancer a relative had, because it really helps us piece together our approach and start to sort of almost predict what might be helpful to look at. So what are some of the risk factors for ovarian cancer? We know that family history really is certainly a risk factor in some families. And it's a proxy for many genetic risk factors, but we know that lifestyle factors will also play a role in terms of how they almost interact with our family history. Age remains the largest risk factor, and I've alluded to that already. We know that half the general population is likely to develop cancer during their lifetime, albeit at older ages. And that's really a reflection of the fact that our body, as humans go, it is prone to natural wear and tear process as we get older. There's hormonal and reproductive factors as well. Endometriosis has been shown to be a little bit of a risk factor for ovarian cancer development. And then the sort of graph that I've put on the slide here is to really show you that there are lots and lots of what we call common variants in our genome that don't give you a high risk. So they're of low penetrance. And what that means is that lots of people will carry them, but they are less likely to cause disease. And that's why they're just common in the general population. In the inherited setting, when you're thinking about specific genes, which I've put there in the purple and the red, actually these are much rarer. So it's not as common for individuals to carry them. And because it's not that common, what that also means is that if you do carry them, the risks are different to the general population. And you don't need to carry a lot of combination of these low risk variants to give you an effect. So having, for example, an alteration in MLH1 or BRCA1, just one alteration might be enough to give you those high risks, whereas in the general population setting, one might need an alteration in hypothetically 20 different spots in the genome to come to that same level of risk. Does that sort of help explain what I'm trying to get across? Yeah. And then there's a third group of families, and 6% of families will possibly, be investigated, maybe offered genetic testing, but may not end up having a clear answer in terms of a genetic answer for why ovarian cancer happened. And we suspect that may be because there are some common single nucleotide or SNPs, single nucleotide polymorphism. So these are subtle sort of differences between all of us as humans in our genome that account for just differences in health, differences in disease risk. And that's also equally important to remember, that although investigations might be done, one might not end up with a very clear answer. And that can sometimes lead to a different level of worry and anxiety and uncertainty to live with as well. So thinking about BRCA1 and BRCA2, so BRCA1 and BRCA2, probably well known by now and definitely more common and spoken about. We know the overlap in families that carry an alteration in these genes with ovarian cancer, but also breast cancer. They're found in approximately 1 in 400 of the general population, but this frequency is different in certain pockets of our population depending on one's ethnic background. So we know that individuals of an Ashkenazi Jewish heritage, the frequency is higher of certain BRCA alterations. So 1 in 40 of them might carry what we call a founder mutation or alteration in these genes. We also know that the risks for ovarian cancer, if a woman has a BRCA1 or BRCA2 mutation, are significantly higher to the general population. And these two graphs are sort of there to depict that. So the left one, this one here, I don't know if you can see my arrow. The dotted line is what the risk is for a lady in the general population, but the blue sort of curve shows you how that risk increases for a lady with a BRCA1 mutation. You can see actually it increases sort of in your late 30s from about 40. And then for BRCA2 similar, you'll see that the dotted line and the general population is there much closer to the baseline, but the blue curve sort of starts to lift off in the late 40s, and around about 50 is when we possibly start to do some interventions. And this is really important because this is giving us a steer as to the advice that we give families, particularly if they're having genetic testing to predict their future risk, and make some informed decisions about when it might be appropriate to do so. So what are moderate risk genes? These are some newer genes that we've sort of been learning about, and these are genes that are different to the BRCA genes, for example. And that's because the amount of risk that they give us if we carry an alteration in them is not quite as high as some of the well-established higher risk genes. The other concept in this scenario is that they are seen in a sort of polygenic setting and can have incomplete penetrance often, particularly in families that present predominantly with breast cancer. So the concept of penetrance of a gene is an important one. So this is something that is trying to tell us, what are the chances of something happening in one's lifetime when you carry a mutation within that gene. So with many genes, we say they have an incomplete penetrance because you can carry the gene alteration. So in essence, you can carry the risk but not develop cancer, for example. So that's what it means, incomplete penetrance. This is more the case with these moderate risk genes, as the risk levels they give are, as I said, lower, but also they're more amenable to being modified by other factors in one's personal and family history. And therefore, it's really becoming a little bit of an art to sort of almost tailor the risk in families that carry some of these genes and give a little bit more bespoke advice about when interventions might be appropriate. And I wanted to give you an example of how this has evolved. So you might have heard of the gene PALB2, again, a slightly newer ovarian cancer predisposition gene. And it took us time to learn about its effect size in the ovarian cancer setting and how that risk might be different between two families, for example. So when the original sort of paper was published and things, there was still a little bit of question mark about, is PALB2 an ovarian cancer risk predisposition gene? We were sort of like, is it not? Well, I can tell you, fast forward sort of 7-8 years now, and we know it is. We know it confers an ovarian cancer lifetime risk of about 5% for a woman. And we also know that in some families that risk could be higher or lower depending on the family history, particularly when we're thinking about the breast cancer side of things, because it not only gives you an ovarian cancer risk, but a much higher breast cancer risk. And that's the bit that can be modified depending on one's family history. So the lesson here is really that knowledge is evolving and the evidence can take time. And sometimes giving ourselves this time to make evidence-based choices is key rather than rushing into, well, this is a gene and they think it may have caused this, so let me just choose an option, because sometimes the evidence does take time and we need to be confident in that evidence before we give the categoric clinical advice. There are now other genes that we know, again, this is in the moderate risk ovarian cancer predisposition genes that I mentioned. So RAD51C, RAD51D, and BRIP1. Much more later ages of onset. So you'll see at the bottom, mean age of onset for RAD51C and D is your late 50s and early 60s, and quite similar with BRIP1, although the numbers have been small so far, so probably a space that we're carefully studying at the moment. And the risks as well, not as high as that we saw for BRCA, for example. You'll note here. I'm just going to maybe pause for 5 seconds to just check, Anna, are there any burning questions from the content so far that I need to clarify? Because otherwise I'm going to move on to a slightly different thing.
No, I think we're okay, Vishakha. We've got a few questions coming in, but I think we can do those at the end as we.
Okay, lovely. Thank you. Thanks. And so just shifting gears a little bit, so you'll remember that I mentioned that in the ovarian cancer setting, we have an overlap with sort of not only breast cancer, but also bowel cancer in terms of a condition called Lynch syndrome. So this is a condition that is caused by mismatch repair deficiency. So there are specific genes, and they're highlighted in this diagram here on the right. which, when they're working well and working normally, help to essentially repair DNA damage. But we know that when they're not working well, that DNA damage fails to get repaired, and therefore you get high risks of the cancers that are mentioned essentially on this slide, and you'll see ovarian cancer featuring there. There are about 5 genes, so there's EpCAM as well, but it's not here because actually it gives very similar risks to another gene here, and you don't worry about that. And you'll see that these gene-specific risks and the ages at which some of these risks may occur are quite different between all the genes, and therefore in the Lynch syndrome setting, we would give gene-specific advice about when screening options might be pertinent, when any risk-reducing surgery might need to happen, but also the extent of risk-reducing surgery. So the thing that I want to point out here is for women, you'll see that if a woman is carrying a PMS2 gene alteration, so this is where my arrow is, if I take your eyes across, the ovarian cancer risk for a woman with a PMS2 alteration is the same as another woman in the general population. So for her, we probably wouldn't advise removal of the ovaries and fallopian tubes, actually, but we might advise just a hysterectomy where only the uterus is removed because of the endometrial risk, which remains higher than the general population, which is different to actually the MLH1 and MSH2 setting, where the ovarian cancer risk is much higher than the general population. I hope that's just helpful to point out why different women with the same condition might end up getting different advice. And the management of Lynch syndrome really consists of a screening for the predominantly bowel cancer risk through 2 yearly colonoscopies, usually starting at 25 for MLH1 and MSH2. But again, you can see for MSH6 and PMS2 later, because the risks for bowel cancer tend to affect individuals at a later age. And in terms of risk reduction, we've just talked about it in the previous slide. For some women, we might advise a hysterectomy with a removal of the ovaries and both fallopian tubes, which is what we call a bilateral salpingo-oophorectomy. So that's what the BSO there stands for. But in women with a PMS2 gene alteration, it would be a hysterectomy alone at 45. And then the use of aspirin to decrease risks, this is what we call chemoprevention, came out of the CAP2 study, and we're just waiting some sort of further results from the CAP3 study to really tell us what optimum dose might be helpful in Lynch carriers. We know that taking aspirin decreases the Lynch risk, and this is something that obviously we would discuss with families with the condition. Thinking about how we go about calculating some of this, how do we know who's at elevated risk? So I've shown you some of the family history criteria, but actually you might have come across this tool, or this might have been mentioned to you. CanRisk is a software that helps us calculate some risks for individuals, but also, calculate that whether an individual has that 10% threshold of carrying a gene alteration or not, for example. And some of the factors it takes into account are family history, but also, if there are other members in the family who have been proven to carry any known cancer susceptibility gene alterations. In the background, it also has this polygenic risk score. So you remember the graph that I showed you where you can have lots and lots of low risk variants in our genome, and those are different between all of us. Well, actually, what the team are trying to do is really harness whether there is any clinical utility in us looking at polygenic risk scores in families with the same condition, and does it lead to, almost fine-tuning some of the already known risks? Does it lead to our advice being even more tailored? We're not there yet, I don't think, but that's certainly a space to keep your eyes and ears open for. It also takes into account lifestyle, hormonal and clinical features, and also some imaging if you're talking about sort of women with breast cancer susceptibility gene changes like BRCA. So what do we do? What do we advise in terms of, if we find a family has an elevated familial ovarian cancer risk? Well, let's look at screening, because I know that will possibly be on your minds, and it has been in the press in previous times, and it's now mentioned in the recent NICE guidelines. We know that there have been some huge limitations to the provision of screening in the ovarian familial cancer setting. And we know that the current tools, such as sort of serial CA125s and ultrasounds, have not been shown to detect disease at an early stage. We also know that they can lead to a high false positive rate, which can mean that, women, often young women, are having unnecessary interventions and could make some very different choices, such as risk-reducing surgery when maybe they haven't completed their families and end up with, long-term morbidity and grief and loss, really. And concern about providing false reassurance if these tools are used for regular screening purposes. And women may then delay the option of risk-reducing surgery, which could then inevitably put them at increased risk, because we know that these tools are not evidence-based. So there's at the moment the data to show that screening measures improve survival are lacking. The recent NICE guidance, states that we should not be considering screening for ovarian cancer to be a substitute for risk-reducing surgery, and that's really key. However, it does caveat that, it could be considered as a temporary measure. So, for example, if you have a sort of 39-year-old lady, we're seeing in clinic, who is yet to have a family of her own and would really like to preserve her fertility for that, and around 40, we might say that actually, due to the lack of ovarian screening, we'd like you to think about having a risk-reducing BSO. Maybe, with a sort of joint decision with her, we could offer 4 monthly CA125s, and it says we need to use a logarithm to interpret those results. And that's where we sort of slightly get stuck, because not everyone has the expertise to use a logarithm, and the services certainly are not set up to do that at the moment. But the onus is on us to figure some of those things out. It also tells us that these women need to be managed through an MDT sort of setup, and we need to see them every year to discuss the fact that risk-reducing ovarian surgery is the gold standard, so that they don't fall through the net, because this is certainly a temporary measure and not a substitute. And this is where I suppose the genetic counselling process can help. It can help to almost have that discussion about the pros and cons of what someone is choosing and why and for how long, and help to make informed choices as they go through that journey. So thinking about risk-reducing bilateral fallopian oophorectomy, or RRBSO. So this is sort of mortality benefit data taken from quite a seminal paper. Of course, it's focusing on a large group of women who have BRCA1 or 2 mutations, but you can see that actually there is certainly a very clear mortality benefit with risk-reducing surgery. So we're talking about a group of healthy women who know that they're carrying this risk, and they're taking sort of almost proactive steps to prevent ovarian cancer happening. And this is where that evidence base comes from, essentially. So I just wanted to really flush it up for you. The RRBSO sort of evidence base for moderate risk ovarian cancer genes is evolving, and certainly there has been some data coming through in the literature in the last 2 to 3 years. Decisions again need to be made by an MDT team that has expertise in managing families with this, because, as I said, it's still a space that we're learning about. And we need to almost refine some of the advice based on the family history, based on the personal history of that individual, based on the prognosis of any ovarian cancer that they may have, etc. And really, consider the benefits of risk reduction versus the impact of an early surgical menopause as well, because actually, particularly for healthy women, what is the optimum age to have this? the NICE guidelines have really helped to give us a little more of a steer on this, and I'll talk about that in a bit. Mutation carriers may also consider a kind of two-step process where under a research setting, so you may have come across the Protector study, which is looking at, is there a benefit in a two-step process whereby the fallopian tubes are removed as a first step, followed by ovarian removal at a later stage. So the advantage of that is that you would be preserving fertility and you wouldn't be facing a surgical menopause. Yet, is there a risk reduction that happens by removing your fallopian tubes? And the science behind this is that we know that a large proportion of what we call ovarian cancers, ovarian tumors, actually arise in the fallopian tubes in the first place. And so that's why this study is important, and it's being run by Professor Manchanda through the BARTS team. And then again, I alluded to the fact that there will be families and women who, despite all investigations, we don't find a known genetic cause in, and we are able to give some advice around, whether having an RRBSO might be helpful in certain families. So please do contact your local genetics teams, even if you've had, for example, a risk assessment or testing elsewhere, not in the NHS or abroad or privately, etc. Make sure you're seeing someone with the right expertise that can really guide you, even if something is not found, essentially. So not to think that these options are always only available to gene carriers. There are some instances and some families where they might be warranted because of the familial risk that we see. So what is the current advice? So this is a slide taken, literally lifted from the NICE guidelines, so I take zero credit for it, really. But you'll see that it's got a really nice table that's telling us, what gene that family gene alteration that family may harbor, the procedure that we would recommend, and the age at which we would want to start having those discussions. It's not telling us that, at 35, if you're a lady with a BRCA1 gene alteration, you have to have your ovaries and fallopian tubes removed. No, it's telling us no earlier than 35, which means we start the discussion at 35, and really personalize when the time is right. And I showed you some of those curves, and really the risk in a kind of significant way in the BRCA1 setting is from 40. So, and it takes time to make these choices. They're not easy choices for young women, for anyone. So please don't go away thinking that that's when the surgery should happen. This is a steer about when those conversations should begin. Okay. And then I thought we could maybe do some thinking together. So this is a family that we looked after, and Catherine was diagnosed with an epithelial ovarian cancer at 66. Was referred to us. We took a family history. There were no other reported cancers in the wider family. Because she had an epithelial ovarian cancer, she met current NHSE genetic testing criteria, and was offered genetic testing, essentially. We know that in her current treatment, Catherine has responded well to carboplatin chemotherapy, but is beginning to struggle with her later cycles, and her oncologists are just starting to think about what options she may have further down the line in terms of treatment. So I accessed the genomic test directory. I identified that Catherine is eligible for testing, and the reason why I've circled this red one here is that in some families you may not actually have a relative alive with ovarian cancer, but that's okay. It's still worth asking the question. It's still worth getting a risk assessment, because we may be able to retrieve some tumor tissue from the deceased relative to do some investigations. And even if we can't do that, we may be able to give just familial risk advice about what interventions might be appropriate for that. We also asked for histology. So this is Catherine's histology on the right here. And you'll see that actually, yes, it confirms that she's had epithelial ovarian cancer, but it also tells us she's had bilateral ovarian tumors. That's also helpful because let's say we offer Catherine gene testing and we don't find a causative gene alteration. That may influence what advice we give her sister, for example, or her daughters in time, knowing that she had 2 primary variants diagnosed. Okay. So Catherine opts for gene testing, and we identify a BRCA2 germline pathogenic variant. And this is this obviously, will open up a whole bunch of things for Catherine and for the wider family that we will talk about. But in terms of treatment, it also opens up the option of her having a more targeted chemotherapy agent, so PARP inhibitors or olaparib, which some of you may have come across. These are known to be particularly effective in the treatment of ovarian cancer in women with BRCA alterations. And this table schematic is really clever, I thought. So I'll just talk you through why these are so effective and helpful. So you've got normal tissue cells here. So this is a table. That's a normal cell. It's a table. It's got 4 legs. All 4 legs are working. Each leg depicts a DNA repair pathway. And remember, I said our DNA is constantly going through changes and we get DNA damage, and we've got certain mechanisms that help to fix that. These are some of the mechanisms. And in this normal cell, this table has all those repair pathways working. Excellent. Okay. In BRCA tumor cells, so that's the table underneath that, in where I've put in the red here, BRCA1/2 deficient tumor cells. Well, the homologous recombination pathway or repair pathway is not working. So 1 leg has come off. It's still just about standing, that table. And so that tumor cell carries on surviving. It carries on existing. That's not a good thing, because in our bodies, we don't really want that. We don't want tumor cells in our body to survive. What a PARP inhibitor does is it actually gets rid of the second leg, one of the other legs, and that destabilizes this tumor cell, which means that it's almost induced cell death. So that tumor cell will be forced to die. And that's particularly effective because that's what we want. We want to get rid of the tumor cells. And this is why this is so specific and works really well in this setting. So I just wanted to use this analogy to tell you why there's so much positivity about it, but also why genetic testing is helpful in guiding treatment decisions and personalizing some of what we're doing now, which we couldn't do a few decades ago. So let's come back to Catherine. So we know that she is carrying a BRCA2 pathogenic variant. We see her in clinic and we start talking to her about what this means for the wider family. She chooses to share this information with her sister, Patricia, and also her children. And you can see that they all access their local genetics teams and have predictive genetic testing. So we call it predictive because these are individuals that are well, healthy, they do not have cancer. And that the result of that genetic test will be predicting their future risks. And that's why it's called that. Predictive testing is done predominantly by genetic counsellors through clinical genetic services. It is not an offer that is made in mainstream medicine for reasons that I'm sure you can appreciate. There's lots of things for us to consider and talk about. And some of the themes that we do get, and just a summary from my experience really, some of the things that we would talk about in a genetic counselling consultation is, just challenges about coping with uncertainties. So things like, even if, you carry a BRCA2 gene alteration, so I could have this discussion with Patricia, that result may not be able to predict whether you get cancer. You may never get cancer. It will not be able to tell you at what age one might develop something, even if that happens. So there's still layers of uncertainty that need to be weaved into the discussion. Impact of diagnosis and treatment, for example, on mood, anxiety, and level of functioning is something I'm sure that some of you might relate to on the call. Impact on relationships. So often we see that in the hereditary setting, There's guilt coming through from individuals that are having to share some really difficult news. Worry about the future, worry about children, but also how they would cope with engaging with a medical environment constantly if they're put on a screening program. Individuals might have neurodiversity, might have learning difficulties in a family, and how we would broach this information with them. Would they need some additional support in those conversations? Who those people might be, and involving them quite early on in the conversation. Impact on identity and self-image if they're considering any risk reduction. Coping with loss and grief. So even getting a sort of predictive test result can often come with loss and grief, even if you're shown to not carry the alteration, because let's say your siblings are. And sometimes it's that survivor guilt that actually your siblings are now having to live with the risk and you escaped it, and that can be quite difficult for individuals. So sometimes I know we spend a lot of time talking about sort of the risks and things for people who carry these gene alterations, but it's not to forget that actually in a family setting there are others that even when they don't carry it can need some further support to come to terms with that. Support around decision making, particularly around surgical interventions. What is right, when is right, why now? And the same questions around testing, why someone needs testing, what they will do with that information, how psychologically ready are they to hear the news? Might they need some psychological support preparation before we launch into testing? But also what's going on in the wider sphere of life, any bereavements, loss, losing parents when someone is young can often have that effect, and how they process and cope with their own risk and genetic test results, I think is a key one. And we often see that if it's not sufficiently explored, after receiving a result, sometimes it takes people, much longer to come to terms with it. And really the aim of genetic counselling is to avoid harm, is to avoid psychological harm, not only for the individual, but also for the wider family. To work with the family, work with the existing relationships and communication channels. I think I don't have long, so I'm going to skip this one. And I just want to talk through some of the models we use in genetic counselling to hopefully give you a little bit of confidence in the process and to show you what that is. So really, we all have a part to play in the genetic counselling process, and the reciprocal engagement model is one that I really like because it's got 5 tenets, and it's a really helpful reminder of who's responsible for what and who's bringing what to the session and why that bit is important. With a kind of recognition that genetic information is key. So in a session, we're all there because we acknowledge and recognize that genetic information is key. But we also recognize that relationships are integral to making the genetic counselling process work, to making it a helpful exchange, and that patients are autonomous individuals that are able to make informed decisions about what is right for them at that particular time. It also is really empowering because actually looking at, particularly someone going through cancer treatment, of course, there's empathy there, but there's also a sense of resilience that they bring because they're going through some hardship. And it's to really harness that resilience in the genetic testing space to really reflect and show them what they're going through and why they're going through that. And why is it any different to the genetic counselling and testing space? Why is the strengths and coping mechanisms that they've been using, for example, in their cancer journey are, very similar to some of the things that might help them when they're making choices around gene testing, making choices about communication within the family. And that actually an exchange of emotions does make a difference. Really knowing what's going on for someone will help me make sure that I have a plan that actually fits them, is helpful, and supports them and prevents them from long-term psychological harm. So genetic counsellors are trained individuals who bring in not only the scientific information that I've been talking about so far, but also some advanced counselling skills, frameworks and tools that we've been trained to do and use. So I am also going to skip through that. And and I'm going to show you another model. And the other thing we do is often when you're sitting in a healthcare setting, you might be on your own with a clinician, and there's a little bit of a kind of power dynamic, and you go, "Oh, clinician knows best. Should I ask this? Should I not?" Da, 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 da. Actually, genetic counselling is probably a space that might feel quite different because we are trained to bring in some of the unsaid, some of the unheard and unseen in the session. We will explore the whole system that individual sits in, not only the family, but their social system, their sort of what work they do, what impact it would have on things like long-term choices, sometimes career choices for young individuals. And so we use, there's lots of systematic theories, but this is one that I wanted to flash up and show you why it's helpful. And then the other one is Burnham's social graces theory. And again, this promotes the consideration of social differences between us. So I don't know, there's about maybe 15 of us on the call, and each of us will have a very different experience and very different value set. And we need to actually establish what that value set is. What are the important things for that individual in a genetic counselling consultation? Things like spirituality, things like, what's culturally acceptable, religiously acceptable. And it's not just about having a blood sample taken and sending it off for testing. It's really about the whole picture. What is right? What are some of the reasons why it's right? And what they want to do so that they're making the right choice for themselves. Some of the support things that we use, again, CBT, we're not trained to do CBT, but we can certainly signpost people that may have high health anxiety for that, and compassion-focused therapies, something that our clinical psychologists use. So again, another support avenue that we can harness through clinical genetic services. And this slide is just to reiterate that actually everyone's risk perception is different. And it's not just a number. The number might stay the same across 10 families, but their experiences are individual, and they will probably speak more than a figure. And that's what genetic counselling is about, exploring all that. The psychological impact of genetic test results, and I know that a lot of families worry about this, but actually there's a lot of literature that feels empowering, and I hope you'll agree, in terms of how family members perceive this information. And you'll see that what are some of the things that are important for family members when this information is communicated? Well, they've told us that actually an accurate understanding of what that test result is and what that means is really important. So if you understand it, hopefully you'll be able to convey it to the wider family. So make sure you ask the questions that you need to. An accurate understanding of the relatives' risk for cancer. If you're conveying that information, you may want to take a leaflet with you. You may want to take a letter with you. And most individuals have a positive reaction to results with the right support and with the right sort of clinical team helping them. Despite what the result is, most report feeling relief after getting a result, because it gives them an avenue and it gives them choices to begin to explore. And there is a real desire for information, particularly in young adults. We know that getting information feels empowering, knowledge feels empowering, and it gives them back a sense of control in terms of making choices for themselves. But equally, they are very open to acknowledging that poor health might come with a particular risk level in time, and to start working on their own coping strategies. So it's certainly not something that's putting people off. And I know that fear can play a real part in how we share information, but actually just to reassure you that there's a lot of benefit in opening up some of these conversations within families. We are immensely lucky at Guy's and St Thomas's to have a embedded clinical psychology service that we use a lot to support our patients and families who are going through the process, to make sure that they have the right support, particularly around sort of risk-reducing surgery. And we're one of the few centres that has an MDT service, so the hereditary breast and ovarian cancer family service. And one of the offerings of this is a one-stop clinic where all these clinicians are there and involved in decision making. The other thing I wanted to show you is that genetic services are, really well prepared to pass on letters that you can then pass on to relatives that might help you share that information, might actually help them seek advice through their GPs to get a local referral to clinical genetics. And this is just a sample letter that I wanted to put up to show you. It doesn't, it essentially says that someone in the family's had gene testing and what gene alteration was identified. And it asks the GP to help that relative get an onward referral. So you don't have to sort of do that and spend your energy on that. And, if there's other letters that we can write that will be helpful, of course, please discuss it with your clinical genetics team. I'm sure they'll be very happy to help. We are also very able to signpost to IAPT, where psychologists are not working within clinical genetics. Relationship issues can inadvertently come up, as you can imagine. We are thinking about young families making some challenging choices, having challenging conversations, and Relate is a really good avenue to explore some of that if needed. The BACP website has a list of registered counsellors and psychologists. So sometimes, if for example, if a relative is living somewhere else and we're not that familiar with what support services are there, this is a good web site to go and access anyone who you could contact directly. And essentially, just your sort of local genetics team, really, they're always really happy to help. They're happy to answer questions. And they are very well used to and trained in dealing with complex family dynamics, giving you support for life, really, in having some of these conversations. Okay, so I'm going to skip that. Don't worry about that. And just to finish off, so as I've said, genetic counselling is a scientific discipline. It's really there to help everyone interpret their results, make informed decisions, and it's not really an add-on, but really a necessity for safe and good genetics care. We work with families, not just individuals, and it's very person-centered. We don't force decisions or choices on individuals. So coming for an appointment does not mean that someone has to sign the consent form to say they want a genetic test. You can very much come and just get information and go away and not make any decisions. That's equally acceptable. We are not therapists or psychologists, so we are not trained to provide long-term support. And I'm sorry to put the last bullet, we do not use candles or aromatherapy, because I get asked that a lot. That's not what the counselling is trying to reflect. So a really quick whistle-stop tour of the landscape of ovarian cancer, familial risk, and some support avenues. And I know some in the past have asked me, I also work privately, that's my website, but there are lots of other providers who do that as well. And your local genetics team might have a list of preferred providers that you might want to access. Thank you.